Hi everyone, Dr. Goel here from PQM Labs, and today we have,
Dr. Maheshwari.
yeah, and you've been with us before, so our audience knows you. We thought we would get your expertise and to have a little conversation about cardiovascular risk factors,
Right.
treatments, and this is going to be the first, I think, in a series. Today
Yeah.
we want to tackle everything about testing. Where's your risk? How do you assess what your risk is at,
Right.
blood test wise or other tests? So
And there's so many tests. Like it's important for everybody to understand all of them so that you can ask for the appropriate ones.
yeah.
I think depending on who you have as a physician or a healthcare provider, you may get some of them and not others. So sometimes you have to advocate for yourself.
Yeah, I think that's an interesting thing, like because I find that there's probably a lot more out there, and we're going to go through this,
Yeah.
and that your doctor may not even be informed. So you almost have to be like the one
Yeah.
advocating.
I
Like
think some doctors might not know about it, but other doctors don't have the time to discuss it all.
that's true.
And so if you bring it up, they will discuss it because you brought it up.
Yeah,
But otherwise, yeah, sometimes the life of a family doctor is very busy. There's a million things they're trying to do. Yeah, if you want them to focus on any one particular area, you have to advocate for yourself, I
yeah.
think. Yeah.
And then, so let's just say, apart from we're going to get into blood testing and all that, lipid profiles and such so on. But if one were just to give general, what would be the top? How would you list it? Cardiovascular risk factors. What would you say for our audience? Which they
In
keep
terms
in
of
mind?
testing,
No, not testing,
oh,
just general, like
yeah, generally we're talking
and how.
about the ones that probably a lot of people know. Smoking,
Yeah.
obviously, is a huge one. So smoking makes everything more or stickier. So you want to avoid smoking, of course. Weight gain will increase your risk of heart
Mhm.
disease, elevated cholesterol, even without weight, and that can be because it's mostly genetic anyway.
Mhm.
But it can also be diet related in some people. It can go up quite a bit. You can modify it quite a bit anyway. What else do we have? Too much alcohol, of course, can affect the heart, depending on what you want to call heart disease. For example, congestive heart failure and hypertension, those would be caused or made worse with things like alcohol. What am I missing here?
Yeah, I think you mentioned it's called weight, blood pressure.
Yeah, high blood pressure, of
Yeah.
course. You want to make sure you get your blood pressure checked. And just cardiovascular fitness. Like if you're sedentary,
Mhm.
your arteries are going to be a little more clogged than the person who's working out on a regular basis. And there's just so much that happens during exercise, so many
Mhm.
chemicals that are released
Yeah,
that counteract some of the damage that goes on with aging.
yeah. And where would you put? I know the framing on risk calculator traditionally been the way one kind of look at this overall, and they assign basically some points. It's a
Right,
pretty rough measure, but they assign 1 point for this and
right.
1 point for high blood pressure. It's a pretty crude measure, but it's stood the test of time.
Yeah, there's so many different ways of looking at it. I use the Framingham risk score when I do executive physicals. I'm using it every day. It's part of our what we tell people, but I also tell people this is only part of it because it's looking at in the formula is basically your total cholesterol, your HDL,
Mhm.
your if you have diabetes or not,
Right.
if you smoke or not, and your age. But that's it. So family history is not in there,
Yeah.
and that's important. And then of
That's,
course ethnicity is not in there.
yeah.
And that's the other thing everybody should know is the Framingham risk score is based on a study done in New England back in, I believe, the 60s. And so it was a very homogeneous population of white men.
Mhm.
So that's not going to apply to everybody. As a matter of fact, we're both South Asian. We
Mhm.
know that South Asians are at higher risk of cardiovascular disease than average, and there's many different populations like that. So
What would be some of the other ones? It's called,
I
say
think even
Hispanics, we call it
yeah,
Hispanics.
Hispanics,
Um,
African Americans,
yeah.
even in terms of at least in terms of waist circumference, we look at we should have a smaller waist circumference than somebody who's not South Asian, but so should East Asian people of East Asian origin. So it doesn't matter if you've lived here your entire life, your genes are still coming from that part of the world.
Mhm.
And if that's the case, then you should be aware that you could be at higher risk for heart disease. Yeah, these are some of the populations that are, it's important to, it's even more important. How about that? It's
Yeah.
even more
Yeah.
important to get screened.
I've seen it even Filipino native people
Hmm.
are extremely high risk
Yeah.
as well. Um,
And then in general, if your family history says that you're at high risk, like if you have a first degree relative, excuse me, that would be a parent or a sibling, if they have heart disease, or there's multiple members with heart disease, that's it's time to get more serious about looking into your numbers and making sure you keep everything as good as you can.
yeah. We talked about, so these are the rough kind of outline of your risk factors. But obviously, there's so many other factors, like you mentioned, ethnicity, family history, and different. Everyone's a little bit genetically different, and so I think we can now go much further with blood testing. It'll be probably the first step when you go in for your annual physical, and you want to assess somebody's risk. You can look at those other factors, but then some people are just don't have the genetic risk factors, or maybe their lifestyle is really impacting whether or not they're going to have high cholesterol or not.
Let's say you're not smoking, your blood pressure's fine.
Yeah.
Your waist circumference is within limits, which is it should be better, but acceptable would be less than 40 inches for men, less than 35 inches for women. But if you're South Asian, now you back that off about 5 inches. So 35 for Asian men, South Asian men, and 30 for women.
So it's inches, by the way. So it's
inches,
in
yes.
metric.
Yes.
What's it in metric?
It is 100 centimeters would be, I think, the 40-inch mark.
Okay. So just saying, like for me, I'm like an 88 or 89. I'm just
You
saying,
measure in centimeters, huh?
yeah, I measure.
So I moved up here from the United States, and I find Canada very confusing in terms of half the people do it in one way and half the people do it another way.
But 100 centimeters would be a lot on my frame. So you're
Yes.
exactly right. I think that we have to do. I think more accurate might be this waist to hip ratio,
Yeah.
which generally you should obviously have a smaller waist than you do hip.
Yeah.
I think it's 80%, a 0.8.
I believe you're right.
Something like that.
Yeah, I don't use that particular measure, but what the important thing is, whether you use the waist
Yes.
alone or the waist to hip,
Yeah.
don't rely on BMI, because BMI can be very inaccurate depending on how muscular you are.
Yeah.
And then there's something called skinny fat.
Yeah, I do see that.
Yeah, which is when you have thin arms and legs because you don't have much muscle there, and then you have a big gut. And that's the worst combination, because your gut is what releases a lot of the things that cause things like heart disease.
Yeah.
Yeah, intra-abdominal fat.
Okay. So
Let's say all of that's good.
Yeah.
What blood test do you do, right? Is that what you're getting at, right?
Yeah, let's go through one by one, and let's
Yeah.
give our viewers some education on that. Okay, so looking at all that, what are the lab tests we would order? We always hear about cholesterol. So maybe let's just talk about what is cholesterol. We always hear cholesterol is bad,
Right.
but is it bad? And you know, you
Yeah.
want to kind of
Yeah, so cholesterol is not inherently bad. Our body needs it, as a matter of fact,
That's right.
for so many body functions.
Yeah.
When it becomes bad is when there's particular types that are not good. There's the LDL. So you'll hear about LDL all the time. And you want to pay attention to the LDL number, because that is the kind that I remember in training many years ago now. We called LDL the garbage, and we called HDL the good cholesterol, if you will, the garbage collector. So it helped clean up some of the stuff that would cause plaques, which is the LDL. So you want to know, is your LDL high? But then you want to know is your HDL low, because that's a separate risk factor.
let's go right into let's talk about LDL.
Let's talk about
lots,
LDL.
lots of LDL.
All right, let's do
LDL is considered pretty much the first one that people look at, right? And
All the
so it
studies
stands
look at
for low density lipoprotein, and so it looks like this is basically carrying
Right. It's a misnomer, because LDL is a lipoprotein that carries the cholesterol in the blood.
Yeah.
So it's not actually the cholesterol, but
Yes.
that the way it's structured is not great for the body compared to how HDL is structured.
And is it the actual lipoproteins that get embedded into the plaques? Like what exactly is happening here? It's not cholesterol that's getting it.
Yeah, the cholesterol is also being
It's going- right.
is being laid down and into the plaque for sure.
It said the LDL particles are basically penetrating the wall and depositing themselves into the
Right.
wall.
And then the
of the-
cholesterol gets there, and then it oxidizes and
Yes.
yeah. So,
Okay. So this LDL, so it basically the type of LDL, there's different types of LDL. I understand that there's it basically the size of the LDL matters. So I think the smaller, the denser LDL is more atherogenic, means it's more dangerous. So one can,
correct. It's
one
more
could
like the
theoretically,
deposit.
yeah, one could theoretically order I think it's called SD-LDL,
Mhm.
the small dense LDL particles. I've never seen this blood test done. Have you ordered it or anything?
No, so when I was in the States, we used to have something called, I think, a VAP test. I can't even remember what it used to be. That was over 15 years ago. I don't know what it stood for. But basically, they would do exactly what you're saying. They would tell you your LDL kind of distribution, if you will.
Mhm.
So small, dense, which is more likely to cause plaques.
Yeah.
All the way to the light and fluffy, which is less worrisome.
Yeah, more buoyant, apparently less atherogenic. So I
Exactly.
think this LDL, and this is what I sometimes have with patients, is sometimes we'll see this number.
Mhm.
And I'm saying, okay, look, we can't just look at this number in isolation. We have, because
Right.
you're right, you could have more problem type of LDL, and you could have LDL is not such a big issue. So one is the size of the LDL, which we talked the diameter.
Yeah.
The other thing is the number of particles.
So that's why you look at when you see the test result come back and it says your LDL is in the US it would be 100 or 70 or whatever it would be. Here it's going to be, let's say, 3.5. Let's say your LDL is 3.5. So we have guidelines on if it's our guideline is basically for the average person it should be below 3.5. That would put you at less risk. If it's above 3.5, you're at increased risk. But that changes. It changes if you have diabetes. It changes if you've already had heart disease.
So what shouldn't everybody aim for? If we say the diabetic should have an LDL under 2, which is considered the guideline,
Right.
Shouldn't everybody have an LDL under 2? Like, why should we only put people at high risk to have this
Because
amazing lipoprotein?
the best way to get there is unfortunately medication.
Yeah.
And so the entire population would be on medication.
There are people who can manage it with lifestyle. I agree that the vast majority of people. I'm just saying.
How many is that in your experience? Do you find a particular demographic if you're vegetarian? I have noticed if you're vegetarian, your LDLs tend to be lower for sure.
Which we also
Not always. It depends on what you eat. But yeah, if you're a healthy vegetarian, then it does tend to be lower. Right?
Yeah.
What else have you seen?
No, I was just saying that. I mean, I would say that 3.5, yes, it's the average or the cutoff. But if you're at your doctor's office, I want to be at 2.5. I want to be definitely under 3. And if I was at 1.9, I would be even happier.
Sure.
There's no reason why it's not detrimental to you for a person to be actually lower than. And if anything, it's probably beneficial.
Yeah, absolutely. There is no low number, too low of a number, basically.
I thought they used to have this concern about it. There's a J curve, like this issue that was actually dangerous to be like at 1.
Right.
For example, have you heard anything about this?
I remember hearing about that vaguely
years ago, but no one talks about that
I think,
now.
Yeah, I think they've proven that's not the case.
Yeah, these new medications we're going to talk about next episode, I've seen people down to like 0.5.
Yeah.
Some really low
Right.
LDL numbers.
And there have been no bad outcomes that we know of.
Yeah.
You need a certain amount of a cholesterol, but I think we need that with any amount, unless you have 0.0.
Yeah.
You probably have enough cholesterol. To your question, most people are going to need medications to get it below 2 in today's world with today's environment, with food everywhere. It's going to be very difficult for most people to get their LDL below 2, but if you can, great, you should.
What about oxidized LDL? Obviously, when LDL gets oxidized, that's when it actually gets more atherogenic.
Right.
That's when it could potentially trigger more inflammation and so on. I've seen people asking me for this oxidized LDL measurement. Have you ever seen that?
No, I have not. Yeah. Have you been able to order it?
Yeah, and I'll come back with it maybe in the next episode, what results actually come back if somebody orders it. But that to me sounds like another way of like further differentiating the problem LDL from the good LDL.
And some of these things that we're talking about may not even be covered by OHIP.
Yeah.
But I think an investment in yourself is so worth it. If you learn about this stuff and you say, "Oh, I want that test," you shouldn't let $100, $200, or whatever it might be turn you off to the test completely, because this is your health. You're taking charge of your health.
Yeah.
OHIP healthcare is for the general population, and there's cost control in that.
There's cost control. I think it's a really important part of this cost control idea.
We can't. The government can't pay for everything for everyone. That's not possible. Our taxes can't go any higher. Otherwise, I'm moving back to the States. But it's not possible. So they will allow us to do certain amount of testing, and they discourage too much testing. For example, the lipids, check every 5 years. If you check every 5 years, like in 5 years, the amount of weight that people gain can be substantial. I don't agree with waiting for 5 years. It doesn't make sense to me.
Yeah.
But we check every year, or at least every 2 years if you're younger, let's say.
Okay, let's move on right to HDL. Let's talk about HDL as considered like the type of lipoprotein, it's called high density lipoprotein, that actually takes the cholesterol back from the cell and returns it back to the liver, I believe, and for reuse.
Yeah.
So it could be
So
either excreted or reused.
I guess why that analogy was so good, garbage collector. So yeah.
This process is called reverse cholesterol transport. And so they've done a number of studies which show that, yes, it reduces a higher HDL, reduces cardiovascular risk.
And they've even worked on creating medications that would raise your HDL. But unfortunately, all of them tended to have too many side effects, and the plug was pulled on almost all of them. I don't know of any that are still being developed at this point. They might be. But all the ones that I heard of many failures, basically. It didn't prove to prevent heart attacks and all that kind of stuff when it was done through a medical.
Go through medication for next time, but apart from medication, traditionally we've been told that exercise was the thing to bring HDL up. I don't know if you've ever seen it do anything.
Yeah, I have. It depends on the person. Ones that, first of all, some people are just gifted and have a high HDL no matter what they do. If you take them out of it, and then you look at people that bike long distances or run ultra marathons or triathlons, all those kind of things, their HDL tends to be above 2. I found in general. I don't know if you notice any pattern like that. But half an hour of activity a day or half an hour of exercise a day probably isn't going to move it much. Isn't going to move that needle on HDL. Maybe an hour, if you get to an hour or more, I think you're going to see it go up substantially. The only other thing, incidentally, that I've seen, I don't know if you've noticed this pattern too. I mean, we learned about it and I've seen it time and time again. I'll have the most sedentary person sitting in front of me and their HDL is at 2 point something. And I'm maybe not 2 point something, because when it's at 2 point something and they're sedentary, I'm thinking it's genetic. But when it's 1.8, I'm like, that's pretty good. Then I learned, so the first question I have for them is, how much alcohol do you have?
Well, you really believe the alcohol could be
Absolutely. I see it all the time.
Oh, wow.
Yeah,
Heard
the
about
people that drink a substantial amount do raise their HDL. Not the way to do it, by the way. We do not recommend that, but it does happen.
No, but if you have, okay, the other thing I sometimes do see is people sometimes will have, if you have a total amount of cholesterol that's high, like high LDL
Right.
and high VLDL, then you potentially also have a high HDL.
Yes, you're correct. Yeah.
That is-
Yeah. But I've seen it in people even that their LDL isn't terrible, maybe 3.7, 3.8. So a little bit high, but their HDL is really high. And it's, oh, that's interesting. But I have noticed that pattern where it's a sedentary person just with alcohol. Now it could be a bias. It could be, maybe it is genetic for them. I don't know.
Right.
But I've noticed the link so often, and I remember learning about alcohol raising it, that I think to myself, that must be it. And here's the evidence that I have that it is it.
Well,
We finally convinced them, listen, you shouldn't drink this much. It's not good for your heart. It's not good for your blood pressure. It's not good for a lot of things. It's not even good for your dementia risk, right?
Yeah.
We get them to cut back their alcohol substantially, and we notice the HDL drops. And they haven't started exercising yet. Actually, in some cases, they have even started exercising, but their HDL has still dropped a lot. They should actually be going up because they're exercising.
Sure.
So the only thing we can link it to is they're not drinking alcohol.
Okay.
Yeah.
Yeah, sounds good. I just looked up a couple of mechanisms of why HDL is so important. We did talk about this whole thing about it's basically removing cholesterol from the cells, bringing it back to liver. It has apparently some antioxidant properties. It's completely new to me. So again, that oxidation of LDL is a major initiator and progressor of atherosclerosis. So HDL is preventing that. It has anti-inflammatory aspects on preventing the adhesion molecules onto the endothelial cells. And like I said, it actually promotes the production of nitric oxide. That was in the endothelial cell.
And nitric oxide was whoever discovered nitric oxide. I can't remember the scientist that
You
discovered
got it
it.
like Nobel Prize.
Because it's such an important chemical. Yeah.
For sure. Okay, so I guess the other thing that comes out of this is that ratio of total cholesterol to HDL is considered an important ratio to look at as well, because it incorporates the amount of HDL compared to your total cholesterol.
Yeah, I don't look at that ratio as much. I don't know what the cutoffs are anyway. I do look at it in terms of, you're almost a 1-to-1 ratio. When someone's a 1-to-1 ratio of LDL to HDL, that's great.
Yeah,
That's great.
I think a 3 is considered very good. A 6 would be
right.
Really bad.
Yeah. And the worst combination is a high LDL and a low HDL, which would be a 6-to-1 ratio, let's say. You got to do something about that. Yeah. And then most of the time, a lot of that is going to be genetic. Right. We can give people some time to try lifestyle changes, but it should be in that case, I would say it should be a short time period. Look, I want you to hit it hard, make lifestyle changes. Let's recheck it in 6 months. Yeah. And if it's not changing, you're at risk. You want to be at risk for years and try lifestyle for years before deciding it's not going to work. I'm pretty aggressive with this, especially when there's a family history. Yeah. Family history to me is so key. Yeah.
Okay, so now that we've talked about the basic, which you pretty much go to every doctor, they'll do your lipid profile. That's what it includes. But we didn't talk about triglycerides.
Right.
Really quickly, that's kind of the third wrong. And it's very interesting. It's obviously we've seen some of these people with the hypertriglyceridemia. I've seen like 10. These people are considered at elevated coronary artery disease risk.
And
But
that's at 10, it's definitely genetic, right?
yeah, that's totally genetic. It doesn't matter what you do. So it's interesting that it isn't necessarily the triglycerides themselves which go into the plaque. It's these triglycerides are basically broken down for energy into glycerol and through fatty acids. And these triglycerides are actually a storage of fat in your body. People who build up a lot of triglycerides end up with more insulin resistance and leads to diabetes, fatty liver.
Very common.
So I think seems to be the mechanism. It's not like an LDL HDL issue.
As a matter of fact, if someone has both high LDL and a high triglycerides, the first thing to approach is the LDL, because the LDL is just so much worse.
Yeah.
But if their LDL is normal, then let's tackle the triglycerides for sure.
Yeah.
Yeah.
Okay. And then some of the newer testing, which I've just started doing now, the Apolipoprotein B.
Actually, one more thing before we go to Apolipoprotein B is the non-HDL. So they are giving that in the cholesterol panel now. You'll get your total cholesterol, LDL, HDL, triglycerides, and now they're giving you non-HDL.
What exactly is the non-HDL?
Non-HDL.
Yeah.
So non-HDL basically, you think of it this way: HDL is your good cholesterol. It's the only good cholesterol.
Yeah.
Theoretically, or again, it's a carrier, but it's a good number to use. So it's non-HDL is everything else, including LDL, triglycerides, but then ones that they don't report to us on, like VLDL,
VLDL.
IDL, which is intermediate density lipoprotein.
Those are all bad.
And they're all bad. And then the last one is, and we'll talk about the extra test that you do for it, is the LP little a.
We're going to get to that.
But those are all technically factored into non-HDL. That's an important number. And some say that the non-HDL is more important than any other number in that profile. And it correlates really well to the APO B, which you're...
Yeah, so let's talk about APO B. Apparently APO B is what's being carried on the LDL molecule.
Yes.
Sorry, it has a direct relationship with the LDL molecule.
It's actually carried on. The reason why it's at such an important number is it's carried on LDL, IDL, VLDL, triglycerides, and lipoprotein A. All the bad particles carry this APO B.
Yeah, so then it's independent. It's almost an independent risk factor apart from LDL. APO B is itself a risk factor.
Yeah, so people are making the point of that's why we should be paying more attention to APO B or non-HDL, because they correlate, and we do both. We run both of them in our wellness panel, and they correlate really well. Usually, as a matter of fact, today I had a patient with a really high HDL. I think it was close to 5, if I'm not mistaken.
Oh,
and
LDL,
excuse me. Yeah. Their triglycerides were also very high. And so the guidelines say that if your triglycerides are very high, you probably shouldn't pay as much attention to the LDL because it throws off everything. And sure enough, when I looked B, the APO B was just slightly high.
Oh, wow. So that's surprising.
Yeah. So it was... So I can understand why they say don't look at the LDL, look at either the non-HDL or the APO B. And again, both were in the same, just slightly high, versus the LDL and the triglycerides, which look quite high. So we might be being thrown off by some of these numbers, which is why it's important to look at more than just the typical cholesterol panel. You got to look at these other things like Apolipoprotein B.
Okay, so we got that one. Then there's the Apolipoprotein A1.
Right.
This is what I meant. This is the particle that's sitting on the HDL.
HDL, correct.
And the higher amount that you have, the better. So it has a protective effect.
Yep.
So then people look at the ratio. I think it's APO B I think it's APO A1 to APO B ratio. So you obviously want more of the A1 and the lower the B.
It's like doing the HDL to LDL ratio, except again, LDL is just one of the bad particles, whereas the APO B is all of the bad particles.
It seems like this is a better marker, and so I think people, I wasn't so aware, I think people should be trying to ask for these blood tests.
And you know what the ratio should be? Because I'm not aware of the APO B. But yeah, that could be an interesting way to go. We don't test for APO A1. But we used to, so I'll find out why we had stopped years ago.
Interesting.
At the clinic on that.
Okay, so let's move on to lipoprotein A, because this is part of now the cardiovascular guidelines, recommending at least once in your life to have a lipoprotein A done.
This is super important, this one. Yeah.
And I've seen this in people way off the map, like into hundreds, and obviously people are down at 15s, and you can't predict it by looking at somebody. It's completely a genetic marker.
So let's talk a little bit about what it is. Lipoprotein A is a particle. It's the worst kind of bad cholesterol, if you will. It's the most likely to cause blockages and all that kind of stuff.
So we just want to jump in there. Why wouldn't medications work on reducing this thing?
Yeah, that's a good question. I'm not sure of the reason why. Well, some of the newer drugs, let's start off with, do reduce it.
Oh.
And then what we don't have yet is like the PCSK9 inhibitors and all that. If you do reduce it, we don't have the studies yet to say that by reducing the Lp(a), you do reduce heart disease risk. But we do know that high levels of Lp(a) are definitely related to higher risk heart disease. As a matter of fact, it's such a strong risk factor that it should be done, like you said, once for everybody, and because you can be surprised. You can have a normal-looking cholesterol panel, relatively normal, and your Lp(a) is very high, and that is concerning.
So where's that Lp(a) hiding? If the cholesterol panel is normal,
Right.
how come it can be still sitting there high without showing up anywhere else? Like if this lipoprotein is sitting, you're saying it's part of all of these other cholesterol molecules.
Right. Well, no, it's a separate kind of.
Oh, it's a separate lipoprotein.
APO
It sits on its own.
B is on all the bad,
Okay.
and lipoprotein A is a little bit separate. And so you can have, let's say, a low LDL number, which looks like, well, I don't know, let's say 2.5.
Yeah.
2.5 looks pretty good, but then you look at the the lipoprotein A, and that's like the normal is 100 nanomoles per liter, I believe.
Yeah.
And it can be, okay, I'll throw out a case to you and you tell me what you think of this. This is a 27-year-old South Asian woman. Women are at lower risk for heart disease prior to menopause. Her lipoprotein A was 337.
Yeah, I've seen this type of number. Yeah, it's crazy.
Wow. I was like, well, what do we do with this? She's only 27. She hasn't had kids yet.
Yeah.
When do you start treatment? Because the treatment for this, if you have a very high lipoprotein A, is that you try to lower the other because you can't lower this, like you said,
That's what I'm saying.
typical
You
statins.
lower the LDL.
Right. So you lower the LDL as much as you can to at least reduce that risk, because you have this increased risk from lipoprotein A. So if we reduce the risk from LDL to as low as we can go, then at least you've kind of offset the risk. But what do you do with someone who's childbearing age? Like, should she be on a cholesterol medication now? If the damage isn't going to she's not going to have a heart attack tomorrow. No. But she's 27. The next 20 years, she's going to lay down a lot of cholesterol. And would it be the right thing to do to put her on a cholesterol medication now when she decides to have children, stop the medication because you can't be on it when you're pregnant, and then restart when she's older? I struggle with that because 27 seems young to me, but the counterpoint is, why would we wait? Because you're just going to be laying down.
That's
There's nothing else we can do.
Prevention. That's
primary prevention,
yeah,
right?
I think that.
And of course, for a 27-year-old, that's hard
I'm not
to hear.
sure we have evidence.
Right.
That's the issue, right? We don't have long-term trials to say what can we prevent, but it does intuitively make sense, right?
Right.
Like if it was you, you might consider
I would
your
probably
family
consider
member and all this.
Yes,
you
I
would
would.
say you'd be doing something. So, we have to kind of everybody's kind of got to advocate a little bit for themselves.
Yeah, like back then, this was years ago, 20 years ago, my best friend from university or from high school, his father passed away in his early 50s from heart disease. And so my friend, we were, 30s, early 30s at that time. He said, what should I do? Like, I have the similar genetic, what's my genetic risk here? I said, he gave me his numbers and they were a little high, but back then we weren't doing the lipoprotein A. But looking at his numbers, I said, based on your family history, now you've got direct evidence, like you have a genetic link there. I would say go on a statin now. You're in your early 30s, and he has. So he's been on. Now he's in his, like me, he's now in his 50s.
Right.
He has not had a heart attack, fortunately.
Great.
He was disappointed to do he did do a CAT scan, a calcium score recently, and it was high. It was average for his age, and he said, I thought the cholesterol medication would have protected me, and I would be lower than average. But I said, that's not necessarily the case. You just went from, if you hadn't been on the cholesterol medication, you would have had calcium plaques build up.
I think it's really important, like, for people to understand. Yeah, like there's a what would have happened if you hadn't done the treatment? Sometimes people like wonder, oh, how come it's not like normal, or am I,
Yeah.
reliant on the medication? Why do I got to take this forever? It's because, if we did nothing,
Right.
you would have a progression. Like
Right.
that's just the nature of aging and
Yeah,
life
it really is. It really
Yeah.
is. And one of the, besides doing wellness, I also do, as we talked about before, weight loss. And one of the things people are struggling with right now is these weight loss medications are amazing, but they keep asking me the question, well, what if something bad comes out of this in 20 years? Like, how do I know it's safe to take this for 20 years? And my question to them is, because obesity is it causes so many problems, including heart disease, is it safe for you not to be taking this? Like, it's all benefit risk, right? So we have to always look at risk versus benefit.
Right,
If you're just doing it to lose 5 or 10 pounds to fit in a bathing suit, probably not a great idea. But if you're doing it because your cholesterol's high, your blood pressure's high, and all this other stuff, it's going to make a big difference for you. So risk versus benefit.
Okay. And so another one we look at is hs-CRP,
Right.
high sensitivity CRP, which is basically a marker for inflammation and independently linked to cardiovascular disease, coronary disease, heart attacks, strokes. What's your thinking about that? Have you been testing as regularly, or?
Yeah, we test it on everybody, and I can tell you people who exercise have lower CRP levels. People who, unless they have some kind of acute injury which can raise it.
Yeah.
People who have their weight in check, it'll be lower. Or people in the weight loss program, for example, who lose weight, we see it go in our program at 5.3 down to an average of 2.2.
Oh, that's great.
That's a huge drop.
Huge.
Yeah. We know, but that's already been published in the papers. Like, if you lose weight, your CRP goes down. But if you exercise, it goes down. If you statins will bring down your CRP. So that's one of their mechanisms of action. Besides lowering your cholesterol, they're also reducing the inflammation in your body, or in the cardiovascular system.
I've seen numbers even up high as 10.
Right.
I don't know how often you see that, but I mean, these people seem to be like everything looks kind of off with their metabolic parameters when people have a CRP around 10.
Yeah, the general rule of thumb is, and there's a big gray area, but the general rule of thumb is if it's 3 to 10, that's above average risk for cardiovascular disease. But if it's above 10, it's probably coming from somewhere else, like we were talking about, inflammation in the knee and sometimes here's where the gray area is. Do you have any back pain? Do you have any joint pain? No. But there's probably some kind of thing that they're living with that doesn't even bother them, that is causing the CRP to be high, which is why it's probably a good idea to have this done routinely, get a baseline when you're young, so that if, it's been climbing slowly over the years, as has my LDL and it has other things, then it's probably more related to heart. Whereas if it's like stable all along and then all of a sudden it shoots up, that's probably going to be something else in the body. Yeah.
Okay, a couple of things that came up. Obviously, an A1C, hemoglobin A1C is we can talk about it in maybe another episode, but marker of glycemic control for the last 3 months, so sugar control. Obviously puts you at higher risk of heart disease. And then I have there's a test out there, I don't know if you've ever done it, it's called the LPPLA2, lipoprotein associated phospholipase. But it's basically, it's an enzyme that's involved in inflammation.
I have not done that.
You have to pay like $300 to get this thing done. They send it out somewhere else.
So if it's high, what do you do with that?
It's basically it's just a marker of high inflammation.
It's sort of like CRP?
Yeah, but apparently independently linked, related to heart disease.
Okay.
But
now is that one more specific? Like,
yeah, because hs-CRP could be linked to any inflammation. This is specific for heart.
Oh, interesting.
Yeah.
Okay.
The issue with these inflammatory markers is very difficult to reduce it. Apart from some lifestyle changes, people ask, okay, how can I reduce inflammation?
Right.
There's no quick medication for that.
Right.
Well, I mean, you're saying statins, obviously.
Statins will, and the other thing that will is low-dose colchicine.
Oh.
So 0.5 milligrams, I think, is the dose. So there's been some studies that have shown that reduces your CRP, and that if you reduce your CRP, you reduce your risk of heart disease as much as if you took a statin for high cholesterol. So the thinking is starting to shift. There's more and more evidence mounting that inflammation is one side and cholesterol is the other side. So we're already working on cholesterol with statins and things like that. But now we should also be paying attention to the CRP to tell us what's the inflammation level. And so different ways to reduce that, like you said, lifestyle, weight loss, but then also the statins can help, and then now this colchicine is an interesting bit. Now, not even cardiologists aren't doing this yet. It's not commonly accepted yet. But I was at a lecture where one cardiologist from the States was really talking about, look at these studies, and he compared. He actually put up the statin studies, and he put up this study, and he said, look at the benefit. It was the same. And his theory, and I actually think he's correct, is that when statins came out, they were new products, so they were patentable. And so obviously there's going to be...
been around a long time.
Right. And somebody's going to make money on statins. So you had somebody interested in pointing out, look at these studies, look at these studies. Colchicine doesn't have that. It's a generic medication that's very affordable. So who's gonna be drawing attention to that other than this poor one cardiologist that's trying to point it all out? I know he's not alone, but it's not being. I don't think it's being advocated enough.
We'll
see.
Do a deep dive on that one.
Yeah.
I think that, you know what, we're potentially going to talk about. I think we should do the CT angiogram, coronary calcium screening, stress test.
Yeah.
You know, myocardial, nuclear scan.
Right.
I think we should do that all separate.
Yeah, stress echo, all of those.
There's so much stuff to talk about.
There is so much.
And I know whether or not we should be doing interventions and on what type of scores, if people are asymptomatic or not.
Right.
So I think we should separate that if you're okay with that.
Yeah, absolutely. And we should qualify that. Neither one of us is a cardiologist. We're more primary care, if you will, and prevention. And you should always talk to your own doctor before listening to us.
But like I said, but I do think that you have to almost take the... I mean, that's the advice I would give, is that do the research, because you might end up knowing more than your cardiologist. So, like I said, these are like, cutting edge type of knowledge.
It's always good to be educated about this kind of stuff, and then have a healthy discussion with your doctors, and and then advocate for what you believe in.
Yeah. All right. Well, thank you, everyone. I hope you enjoyed the video today. Please like and subscribe, and we'll see you next time.
See you next time. Okay.